So it's a group of protein misfolding disorders, mainly characterized by either intracellular or extracellular, but mostly extracellular deposition of insoluble polymeric protein fibrils in tissues and organs. So extracellular deposition is the most important aspect. Insoluble polymeric protein fibrils. Now, generally the cellular machinery is very much adapted in that way that there is this protein synthesis secretion and they come to the correct configuration, conformation, tertiary conformation, and they function to eliminate any of the proteins which are misfolded during this process. Okay, so this is mainly carried by ubiquitin, and it will target correctly misfolded proteins. It will identify the misfolded proteins, and then finally the proteasomes. The proteasomes will be destroying, okay, what is not necessary. This is a normal, okay, with this just normality, what is happening in this normal protein. Now, there are genetic mutations which may result in incorrect processing, and how this may favor misfolding. So, I already told you, earlier it was thought that it is only extracellular, but now it is thought that it could be even intracellular, but predominantly it is still extracellular. In misfolded subunit, they assume this beta plated sheet. You know, whenever secondary protein structures, either alpha helix or it may be a beta plated sheet. So they get to a beta plated sheet structural conformation, and that leads to the formation of, you have, okay, so you have two or more this subunits, they form oligomers, and then the fibrils with, these are fibrils with unique staining properties. Okay, so beta plated structures have these unique staining properties with combo red and polarized light. We are going to see a different, okay, a picture will be dealing with again. Now amyloid means it starts like resemblance of deposits under the microscope, just with iodine, okay, earlier, and sulfuric acid. It used to turn blue, so that's why, okay, they labeled it as amyloid initially. Now, so these are the points which you need to keep in mind, okay, before going into the disease problem. Now, for basic understanding, okay, we need to just understand that the classification is introducible, either systemic or localized. You can either label it as acquired or inherited forms and the different clinical patterns. So, most of the time, what will stand for is whether it is systemic or localized type. Now, the nomenclature is always, you call it as AA, amyloidosis, AL, or different types of amyloidosis. The A is for amyloidosis. The X aspect is particularly the protein present in the fiber. Okay, for example, the protein which is misfolded and that is being deposited in the extracellular space is transthyretin. Transthyretin. Then it is called amyloid transthyretin. ATTR. Okay, so that each label now you have separate. Okay, based on the protein which is there, precursor protein, we label them according to that as A. Okay, and whatever protein. Next thing is we will be dealing mainly with systemic amyloidosis. I to point about localized amyloidosis. Now, I told you the commonest systemic amyloidosis which we come across will be AL amyloidosis. So L is for the light chains. The amyloid composed of immunoglobulin light chains. Next one, AA amyloidosis, is one where you have any chronic inflammatory state, or a chronic infectious state, like tuberculosis. You develop fibrosis, you develop bronchiectasis, then you develop amyloidosis. Okay, so in end stage is actually amyloidosis, which is, so any infection, operate tuberculosis, any infection long-standing, you are not going to treat, then it's going to land up as fibrosis and later on turning into amyloidosis. So there, the protein is, precursor protein is serum amyloid. Serum amyloid associated protein. Okay, so it will be chronic inflammation or it will be infection. You see some of the causes. Other most common aspects I already told you about the transport protein for thyroid hormone and retinol binding protein, that is transthyretin. So this is the one which gets misfolded. So no, we don't know what are the reasons. It may be hereditary or it may be acquired. But this misfolding of this protein is the one which causes spiral formation. I already told you. You have diagnosed and then you have insoluble amyloid fibrils. Now A beta 2 microglobulin is the main culprit because of protein. Earlier, more commonly seen in patients who are undergoing dialysis. Once you start dialysis, and as time goes on, these proteins were not actually cleared up by the dialysis membrane. Okay, so they used to be accumulating in the body and then they used to get deposited and usually related to dialysis related protein accumulation, beta 2 microglobulin. But nowadays, the dialysis membranes are being made better. Okay, they have good flow and they have good permeability, and this problem is actually about it at current diagnosis. So that is not so common, except now you see Alzheimer's dementia. There also again this beta 2 that is where we commonly see now, and that is related to now. Coming to localized amyloidosis, they deposit in tissues, maybe retrobronchial urinary tract, skin. They are derived from monoclonal light chains, but see always they may be derived, but they are not from a systemic clonal plasma cell. Systemic clonal, that is multiple. Okay, you have clones which are producing increased number of. So, for example, you have plasma cells, you have a clone. Okay, that is going to result in multiple myelin. Here, there is no definite clone, but definitely these deposits are derived from monoclonal light chains. They do not develop systemic disease, no cardiac, renal, hepatic, or no involvement, and hence they do not require any form of treatment. And there may be damage to the affected site. Nasal area will be there. They may cause bleeding, chronic bleeding, tracheobronchial obstruction, hematuria. They may be causing only a problem at the defined localized site. The clinical course is benign, and once you identify that as amyloid, you are going to just excision. So you can look it all together. So localized amyloidosis, though there is a derivation of the deposit from the monoclonal light chain, it is not a systemic disease. It is not it, and it's usually benign and only surgical excision may be. So that is about localized. So many proteins are there. If like calcitonin, if you have calcitonin, precursor this protein is going to be then you have the thyroid deposits. So the patient may have you identify it as localized amyloidosis, you will remove it your mind. But that's some 6 to 7 to 8 different types of localized amyloidosis precursor for them. Do not go into it, but remember it doesn't cause any harm except for the local manifestations, and local manifestations can be taken care of by just excision of the, if possible, excision of the deposit. Now, as such amyloid deposits found anywhere in any tissue of the body, the gingiva and the rectal mucosa are the common sites where we easily access this in the wards also. You know, we are thinking abdominal fat pad aspiration. They will aspirate the abdominal fat, and that is going to help you apart from the kidney, heart, liver, tongue, or GI tract. Anywhere there could be a amyloid deposit. The regular beta-pleated structure of amyloid deposits is the reason for this apple green birefringence on polarized light microscopy after convoluted staining. Or this can be identified by electron microscopy by a pair of amyloid. So, main thing, polarized microscopy is the one we are going to use to find out this apple green birefringence. Electron microscopy we hardly need to further confirm. Now, to identify the precursor type of fibrils, you need to combine them with antibodies, do specific markers, immunohistochemistry or immunoelectron microscopy, or either you can extract and find out the biochemical analysis with the help of mass spectrometry. So this will be the thing. First you identify whether it's amyloid or not. Then you identify what type. So light chain means which light chain, whether it's G, A, M, D or E. And again, what is the subtype? Are you dealing with the kappa type or am I dealing with the lambda type? Why I need this? This is because there are certain prognostic issues. Okay, so definitely which type of immunoglobulin you need to find and which type kappa or lambda light chain you need to find. That you do with the help of immunostatistics. So next thing is, so you have a clinical suspicion of amyloidosis. Okay, tissue biopsy, congruent staining of abdominal fat, and then I already told you immunohistochemical staining of biopsy. Either kappa, lambda light chain, amyloid A, transthyretin, you can find out what type it is. Okay, so here, for example, monoclonal protein in serum or urine, you have a plasma cell dysplasia in the bone marrow. It is AL amyloidosis. Already told you earlier about chronic inflammatory disease and transthyretin. In sometimes elderly people, you have the same normal transthyretin. Okay, so that is accumulating, and more than 65 years, it may cause senile type of amyloidosis. Now, same way, different enzymes, fibrinogen, lysozyme, gelsolin, any of the compounds can be, any of the precursor protein can be picked up. Now, fibril formation is because of, so either these proteins, they go reversible unfolding or misfolding. The misfolded proteins form oligomeric aggregates, a higher level polymers, and then form fibrils. These oligomers are the most toxic aspect. They react with cells and they induce them to form reactive oxygen species and stress signaling. Fibrils, what they do, they go and get deposited in the organs. Because there is extensive deposition, there is going to be failure of functional organs. So what happens, there is misfolding, there is formation of oligomers, then polymer, and then fibril formation. Now, which is more toxic? The oligomers are more toxic. Why all this is important is, whatever drugs we are going to use, are they going to stop this production of fibrils? Stop the production of fibrils. Or if there is an established fibril, can we do anything about the established deposit, established fibril deposit? So most of the time the drugs are all targeting this area only. That is the protection of the fibrils. They stop this polygomers, okay, and then make them inactive or further, okay, proceeding to form fibril formation. So all the drugs are active in decreasing the production of fibril. That is the major, most of the drugs we have are only based on this concept. Now, what happens in the kidney? Most of the time it's a nephrotic ventricular. So nephrotic syndrome, patient will be presenting volume overload, okay, hyperalbuminemia, like this volume overload. So that is the generalized picture in the renal environment most of the time. Now, cardiac patient, you have concentric ventricular hypertrophy, you have diastolic dysfunction, and elevation of cardiac biomarkers. Any of the cardiac biomarkers can be used. So generally, whenever there is ventricular hypertrophy, thickened septum, thickened ventricles, then again, so you have, along with that, you have hepatomegaly, you have splenomegaly, okay, all organ involvement, multiple organ involvement, organomegaly. Then you think in terms of whether it could be amyloidosis per se. Okay. So liver, mainly obstructive type pattern, okay, cholestatic pattern is the one which is seen in the liver. Endocrine, again, these deposits may be there in the thyroid, in the adrenal, or in the pituitary, and they may be causing accordingly, whether they may cause adrenal insufficiency or hypothyroidism. Now, so mainly renal and cardiac involvement is the one which is the most important. The commonest cause of death also will be again whether it's cardiac or whether there is renal involvement. So, one or two slides about each of the common amyloidosis which we come across. So, AL amyloidosis, after age 40, progressive and fatal completed. Already told you there is a clonal expansion of bone marrow plasma cells that secrete a monoclonal immunoglobulin light chain. This can occur with any of the other diseases like multiple myeloma or any B cell lymphoproliferative disease. Okay, it could be NHL or Parkinson's. Now, Amyloid deposits are composed of neuronal light chains, particularly mostly in the lambda type. Apart from this amyloid, you may have deposition of other components like amyloid P component, glycosamine, and methionine. So here, mainly you need to remember about the plasma cell. There is a float which is going to secrete increased amount of monoclonal light chain. Normally, when you are doing a urine routine testing, the urine routine testing will not ensure that there is no proteinuria. There is no proteinuria because the monoclonal light chain will not be detected in a urine standard urine routine examination. Standard urine routine examination. Okay, so that's why you have to go for either a urine electrophoresis or a serum electrophoresis to identify these light chains. Now, what are the clinical pictures apart from what I told you? Okay, so most of the time the people, they don't come to us very late, 1 or 2 years later also, because they're only complaining with fatigue and weight loss. Fatigue and weight loss. So they'll be seen locally, and only when this comes to us, like you have anasarca like picture, that time only they come and reach their capacity. The renal involvement 70 to 80%, nephrotic proteinuria. Very rarely you may have a situation where there is, instead of there is a interstitial deposit, the amyloid deposit is the interstitium. So there is no proteinuria, but patient is in renal failure. Okay, there is no proteinuria. That is very rare. Most common is always nephrotic. Cardiac 50 to 60%, leading cause of death. So there will be sinus rhythm, but still there will be atrial contractility will be very poor. So because of atrial contractility, most of the time cases thromboepathy, have a clot formation and risk of atrial thromboid and this. So this can be easily picked up from the echo, ECG, and okay, you can do MRI, you can try to find. But most of the time ECG and echo itself will be helping you to identify what is the cardiac pathology. The common thing in the ECG they say is the low voltage complexes into limb leads. Okay, so anything a low voltage complex is one where limb leads are showing less than 5 mm height. The amplitude is less than 5 mm and the chest leads will have 10 mm. Right. Okay, so if it is less than 10 mm or less than 5 mm these are limb leads, then it is called low voltage complex. It can be simply because of obesity, you have COPD, it can be because of that. But here, whenever you have a low voltage complex and along with that you have features of ventricular hypertrophy, you have features of ventricular hypertrophy, then you can think in terms of whether am I dealing with amyloidosis. Now, other important aspect is the many conditions cause a pseudo infarction pattern. That means okay, there appears to be an infarct from the ECG, but actually there is no infarct. Here, for example, the ECG you want to detect infarct. The common is the one which you are going to find, wave you will find is a Q wave. The presence of Q wave indicates infarction. Okay, so even a person who had inferior antivolume line for years together, the Q wave will be present. So you take a ECG, you find out that there are prominent Q wave, then it indicates that there is whole infarction. So here, if you see the chest lead V1, V2 or V3, V1, V2 particularly, there are present. There are Q waves in V1, V2, thinking that it's an antrocephaly, but actually there is no infarction as such. So subsequently when you do an echo, you don't find any evidence of infarction there. You have to think in terms of whether it is amyloidosis. So echo constantly thickened ventricles, diastolic dysfunction, and there is a abnormal global longitudinal straight pattern. Okay, so main thing you need to remember, ventricular thickening and diastolic dysfunction. There used to be a sparkling appearance, you used to do an echo, but those are the older machines. Now current machines and all, we are not able to pick up this sparkly appearance as such. Now, apart from this, MRI after all this you are still in confusion, you can do an MRI to find out about the wall thickness and after that contrast enhancement. Commonly we give gadolinium, so 8 gadolinium. So you can see that shining sparkling here. So whenever they used to do an echo, you find this out of nature, immediately they used to, okay, right now probably rule out amyloidosis, okay, sparkling nature. Now, neuropathy, what form they can present? Mostly peripheral neuropathy or autonomic neuropathy. Okay, amyloidosis always, okay, peripheral neuropathy or it is a autonomic neuropathy. Autonomic neuropathy, you know each system, what are the common findings in each system. Okay, for example, okay, you have autonomic neuropathy, GI tract, okay, apart from dry eyes, mouth, diarrhea it may be there, or it could be constipation. Then history of impotence we need to ask, and orthostatic hypotension, postural giddiness, okay, or bladder disturbance. These are all features. You have to ask about two things. One, is it a peripheral neuropathy or whether it is a autonomic neuropathy. So asking history, okay, in a patient who has hepatomegaly, splenomegaly, and okay, the patient is presenting with another form, okay, then you have to think in terms of okay, whether nerve involvement is there, ask them about autonomic features. So two important aspects, these two systems we need to, okay, so weakness and sensory disturbance we need to ask along with autonomic features. Hepatic involvement, hepatomegaly, I already told you, cholestasis, and there may not be significant splenomegaly, but functional hyposplenism. So more than all this which I told you, the common thing where we pick up amyloidosis is the presentation of macroglossia, deposition of amylin, okay, the tongue. So you have a large tongue. So whenever you see a large tongue, okay, you're going to think always one thing you're going to keep in mind is macroglossia. Then other important aspect which is frightening in the sense that now the patient has very easy bruising. So even small injuries, they develop severe bruising. So amyloid deposits are there in the capillaries, or it is because of deficiency of clotting factor 10, it binds to the amyloid. So we have something like most of the time it is seen below the eyes. Okay, so raccoon eyes, I'll show you some picture. Nail changes, again dystrophic nails will be there, and you hair loss, apart from that sometimes some joint involvement can be there. Most of the time, okay, easy bruising, macroglycia and dystrophic nails. Okay, these are the three things which are very common. You need to remember this. So you have a large tongue. How to identify one? You know it's apparently large. Okay, fine, but you can see the teeth, the markings of the teeth on the sides of the tongue. The marking of the teeth on the sides of the tongue. That indicates that definitely it is enlarged. That's why the markings of the tongue. Okay, otherwise it should not be. Sometimes it will be apparent. Okay, large tongue macroglossia, but it may not be a true macroglossia. So you can identify always the tooth markings are there. Okay, then imprints are there. Then definitely. So again, this other picture I told you about this recognize not only specific amyloidosis, other conditions are there, but definitely whenever you have okay, you're going to the first aspect you're going to think of is amyloidosis. Then dystrophic nails. So the first picture is the dystrophic nails, and with therapy the change in okay, the nail changes okay are after treatment they are much better than what is seen on the first part A. Just dystrophy of the nails, okay, so thickening, like you think like psoriasis, some flattening is there, okay, some hardening is there, and the ridges are very prominent, okay, that way you will be able to identify. So, most of the things what we need to diagnose, I already told you, just a recap only, identification of a coronal class muscle or a lipoproliferative process is the most important thing. What we are going to do, the first thing you are going to do is a serum or urine electrophoresis. Serum protein and urine electrophoresis. They are not useful but as screening test because okay, there are not sufficient quantities to produce a. What we are looking whenever you are thinking of myeloma, the first thing you see is the altered albumin globulin ratio, Ag ratio is altered. You have renal failure, you have back pain. That is the indication of myeloma. So whenever you have a CKD or anybody with a renal failure, you have severe back pain, anemia is going to be there. Then the diagnosis always you have to rule out a multiple myeloma. You look for medication. On one side you send for urine benzoate protein, maybe see 30 cases. Okay, then you send for serum and urine electrophoresis. Now, so I told you sufficient quantities will not be there to produce a spike. Okay, so gamma globulin. Now, the next thing is to have a serum immunofixation electrophoresis, where monoclonal light chain or the whole immunoglobulin can be detected. So when you say immunofixation electrophoresis, they add antibodies against each of these. Okay, G, A, M, D, and E, they add antibodies. So you can pick up which one is showing up on the same thing. Again, you do the same electrophoresis only. Okay, so but you add antibodies and you're going to find out the kappa lambda and also which type of immunoglobulin it is. So you have a monoclonal serum protein, you identified it, okay, but then is it whether it's really a amyloidosis or is it multiple myeloma or is it any of the, you have a 70-year-old, no, you are trying to identify monoclonal protein. We don't know, many people have this, but it's not a very sure thing. Any sure thing. So that is what MGUS, monoclonal gammopathy with uncertain elderly people. Okay, again biopsy proven. Only thing way you have to find out is, okay, to find out whether you see the amyloid fibrils. And now this is the monoclonal pattern of serum protein. So you see the gamma, then there's the big spike. Now immunofixation, you can identify say IgG is here and kappa gene. You can be able to pick up the band. So this is what we commonly do, and then they do a free light chain assay to see how much what is the quantification, okay, how much of the light chain. So electrophoresis, then immunofixation is the one which is going to help you to identify which type of immunoglobulin is there. Now polarized microscopy, concurrent staining. This is the apple green bioresingen, which is because of the beta pleated structure. Okay, so this is the one which is going to confirm that whether it is definitely amyloid or not. Okay, the fibrils, what type of fibrils are there. Now, so few words about therapy. Median survival period without treatment is only 1 to 2 years. So what we are going to use is high dose melphalan and a stem cell transplant. But most of the people, only 30% of the people will be eligible even for this therapy. So the next therapy is either from oral melphalan along with dexamethasone therapy. But now newer drugs like bortezomib, proteasome, okay, bitter. So you have bortezomib along with, okay, you have melphalan, dexamethasone, or nowadays newer drugs are coming up. You have even oral drugs. Bortezomib is usually given subcutaneous most of the time. Now oral drugs, dexamethasone, and this week monoclonal antibodies or anti-CD38 are coming up. Okay, so main thing you remember, okay, you are going to put on chemotherapy and remember stem cell transplant. That is the best way out of the picture, and it gives remission in 40% of the patients. And all this plasma clonal cells will be removed, okay, will be destroyed in the bone marrow, and all the 6 to 12 months after you can see a hematology. But most of the time, now we are going towards other chemotherapy drugs. I told you, remember what is over dexamethasone and the newer drug daratumumab. So this is the major plan of therapy. Now regarding cardiac failure and renal failure, you know, cardiac failure, proteinuria, you are going to add. Okay, renal failure, proteinuria, you are going to put on ACE inhibitors. Volume overload, you are going to manage with diuretics. Apart from that, you have to understand that you should not give, okay, this digoxin. Okay, we will not be using digoxin, calcium channel blocker, and beta blocker are relatively contraindicated. So what are we using? It is amiodarone most of the time, or atrial okay, because I told you that atrial contraction is very poor and atrial thrombus formation, there is a role for anticoagulation, and for postural hypotension, autonomic symptoms, we can use nitrogen as well. So for arrhythmias, they are going to be recurrent in spite of treatment. We are going to put them on automated implantable treatment. These are all symptomatic factors. So diuretics, ACE inhibitors, along with, okay, apart from that, antiarrhythmics and postural hypotension. So just 1 or 2 slides on the other types of amyloidosis. AA amyloidosis is the most frequent systemic amyloidosis seen in children. Chronic inflammation, I told you, rheumatoid arthritis is the one which we see very commonly. Their patients are there taking drugs for 15 years. Or sometimes you have people who melt their nails, for example, they develop fevers on and off. Okay, periodic fever syndromes. Okay, you evaluate, there is no specific infectious cause, okay, because of the mutation, and that, okay, that there are so many, about 7 to 8 periodic fever syndromes. Okay, these people have, they develop chronic inflammation, there is no infection. Okay, apart from that, ankylosing spondylitis, any chronic inflammatory condition, you need to remember. I just give you some examples. Chronic infections, tuberculosis, subacute bacterial enterocolitis, osteomyelitis, Okay, these are the chronic infection. Other conditions where you may develop multiple lymph nodes. Okay, it may be Castleman's disease or lymphoma or venous cell loss. Just remember chronic inflammation and chronic infection. These are the two important components. The organ involvement, usually the kidneys, the heart involvement is late. What is the precursor protein here? It is serum amyloid A, which is synthesized in the transport. Now, several years of increased serum amyloid A has to be there. Okay, before you have a fibril example, this fibril formation. Okay. Serum amyloid A is chronic infection and chronic inflammation. So underlying, you have to treat the underlying inflammatory or infectious disease. So decrease SAA, serum amyloid A results in decreased fibril formation. If, for example, familial Mediterranean fever, oxygen is useful, but not in other cases. Other cases where TNF alpha or interleukin 1 or 6 antagonists will be used. Okay, they inhibit the hepatic production and they limit the deposition also, and they interrupt the cytokine signaling. Okay, so all this work, okay, this anti-inflammatory cytokine, particularly antagonist they will use. So this is the main management in case of primary conditions to be complete. So I told you about this transthyretin. Okay, it's familiar, one of the familiar causes of amyloidosis. It's autosomal dominant, particularly seen in the African population. So you have a normal transthyretin which is misfolded and aggregated. You see in the elderly for phenyl amyloidosis. I already told you the oligomers are the ones which are more toxic. They target the peripheral nerves and the autonomic nervous system. So again, a polyneuropathy or autonomic nervous system. So treatment, okay, so once you have orthotopic liver transplant, it has to be done. Useful only in certain patients who have a mutation as a D30 PTTR, but otherwise not useful. And very useful only in the early periods, early peripheral attack today you are going to stabilization of the circulating TTR tetramers. They prevent tetramer monomer release. Okay, I told you. Okay, earlier so the tetramer is the one which is going to be the most toxic. So some of the drugs like diflunisal and a newer drug, okay, a thyroxine mimetic has been found to be useful in stabilizing this TTR tetramers. Now, hepatic TTR production itself we can stop by means of gene silencing. These are not yet out. Okay, they are just only in trials. Now the last one, A beta 2, I already told you, seen in long-term dialysis patient because they are not filtered. So they manifest as skin carpal tunnel syndrome or joint effusion, spondyloarthropathy. Okay, no specific treatment. Only thing is about renal transplantation. So that is the only way out. But most of the time now I told you, with the new dialysis machine, you don't come across this protein also filtered. Okay, it's also filtered, so you don't develop this complication. So the important thing you need to remember, when am I going to think of amyloidosis? So you have multi-organ involvement, I told you. So unexplained nephropathy, you have cardiac involvement and you have neurological involvement, particularly neuropathy or autonomic neuropathy. Soft tissue finding, macroplasia, periorbital echinosis, and then you very simple test combo, just local anesthesia only. You are doing this fat aspiration, abdominal fat aspiration. Systemic amyloidosis definitely critical condition. So the idea is mainly to limit the formation of this amyloidogenic protein. Whatever is existing amyloid, it's very difficult. Okay, but now there are clinical trials are there on newer drugs to identify what can we do with already deposited amyloid. Okay, so that aspect still only research is going on. So most of the drugs are only targeting the protection of this amyloid. So this is the picture. So multi-organ involvement, again, nephropathy, cardiomyopathy or neuropathy. This finding the macroplasia or periorbital. Now, other multi-organ involvement condition we will be dealing with this part. Okay, that is sarcoidosis. Okay. So, when you think of sarcoidosis, just like TB, they will be presenting most of the time there also they develop granuloma. Only thing is there, the granulomas are not KCD. Not KCD, sarcoidosis is is non-Asiatic. So inflammatory disease characterized by non-Asiatic granomas who are more often. Now, what are the agents of sarcoidosis? Nobody still, we don't know what are the agent. Triggered often, there is a triggering of an inflammatory response. You have a susceptible host. Okay, what is the organism? See, maybe Propionibacterium acne, or it could be just Mycobacterium tuberculosis catalase or okay, so these are the two particular agents which they are thinking that it could be particularly Mycobacterium tuberculosis catalase alloxylase. This is the agent which is triggering sarcoidosis. So we are going to diagnose. Common now, women are more susceptible than men. Common in Arctic countries. Here in India, as such, it is very less common already, or we are not detecting it, we are not identifying because lack of knowledge on it. Okay, so the prevalence 20 to 60 per lakh population. Young people above the age of 18 years. Most cases are sporadic. Familial cases are very rare. So what is the pathophysiology and immunopathogenesis? Antigen presenting cell with the help of a CD helper T cell, CD4 T cell. Okay, they antigen presenting cell presents this, we don't know which antigen. Okay, the implies unknown antigen. So the antigen is presented to the CD4 helper T cell, and then they secrete cytokines. Okay, so interferon gamma, TNF and interferon gamma, these are the most important cytokines that result in granuloma formation. And then subsequently, either there is recovery, rapid recovery, and okay, or there is presence of fibrosis. Okay, so two things can happen. Okay, so they most of the time they will spontaneously recover, or with therapy, or they may land up with necrosis. So just at least these two things. Okay, that the CD4 helper T cells are the one which are the main components in pathogenesis. You need to know the other things. Okay, you know cytokines, granuloma formation, and always it results in either fibrosis or restoration. So only about the CD4 T cell you need to helper T cell is the main culprit which is there. Now most of the time asymptomatic, you take a chest. Common thing you identify is for some other reason you take a chest X-ray, then you identify a bilateral hilar adenopathy. Bilateral hilar adenopathy or mediastinal adenopathy. Then you think of whether by dealing with sarcoidosis or not. Symptoms vary according to the organ involved. Non-specific, again fatigue, fever, any inflammatory state. You have fatigue, fever, night sweats, and pain. Commonest organ to be involved is always the lung. Okay, so pulmonary sarcoidosis is the most important organ. So what next comes? Okay, the skin. Okay, then eyes. These are the common three organs which are going to be there. We will discuss about few organs around. So more than 90% of the time, pulmonary organ will be there. Okay, I will be putting up the different staging based on the X-ray which is described. Okay. So this is scanning staging, described very early in 1960. So you have stage 1, stage 2, 3 and 4. So stage 1 is just finding a bilateral hilar adenopathy without any infiltration. Stage 2 same with the infiltration. Stage 3 only infiltrates are available. Infiltrates can be seen in the X-ray. And stage 4 is presence of fibrosis. Now, so X-rays can help you to identify what you are dealing with. Now infiltrates in sarcoidosis are predominantly upper lobe. When you think of upper lobe, next diagnosis which you are going to come is mostly the first diagnosis which you are going to think of is tuberculosis. So other diagnoses which you can think of are hypersensitivity pneumonitis. Any patient presenting now is going to be acute onset fever, cough, breathlessness. Okay, hypersensitivity pneumonitis should be thought about because it's going to respond very well to steroids. Okay, otherwise you'll think of pneumonia, you're going to treat with antibiotics. So silicosis based on the exposure and Langerhans cell histiocytosis should be thought of. Okay, most of the time, by the time it presents with X-ray features, there will be definitely other systemic features. So infectious causes, one is tuberculosis and pneumocystis pneumonia. These are the two things which you are going to think of. Now regarding ILD, they will be presenting both obstructive pattern or a restrictive pattern. One of the few diseases where there is both patterns. Okay, it may present as either a restrictive pattern on a PFT or a obstructive pattern. Obstructive pattern mainly airway hyperactivity and okay, it will be airway obstruction. Now another important aspect is development of pulmonary hypertension. It's seen less than 5%. It's mostly because of direct vascular involvement. One but interesting thing is the reversible pulmonary hypertension. In the reversible pulmonary hypertension, okay, with the treatment they are going to respond very well. So 90% of the time, stage 1 disease, most of the time there is spontaneous reduction. Only in stage 4 disease, okay, less than 5% of the patient will go. So XIL we can pick up, but to identify it clearly the extent of the disease, then only you do a CT. Now there are certain syndromes which are associated with sarcoidosis. We need to remember. One, okay, is the Lofgren syndrome. It's an acute form of sarcoidosis. Okay, so what is there? Bilateral hilar nodes. That is the most important aspect, and presence of multiple erythematous, either macular lesions. Macular lesions. Erythema nodes. Okay, so mostly seen in the shin, the lower limbs, and mostly seen in the shin. So you have, along with the, sometimes you may have arthritis. Sometimes you may have arthritis. So the main complaint will be, okay, they're going to come with some cough, cold, and okay, particularly the erythema nodes, some of these features suddenly developing this papular lesions, and then coming with some cough and cold, and you take an X-ray, you see hilar retinopathy. Okay, then only you are going to identify this Lofgren syndrome. Arthritis is less common. So, okay, these are the self-limiting type most of the time. It doesn't require any biopsy for diagnosis. The other thing is Clearfoot syndrome, described in 1909. Okay, it's a rare presentation of sarcoidosis. So here again you have like an alcoholic, you have bilateral carotid enlargement and presence of facial palsy and eye involvement in the form of anterior uveitis along with fever. So anybody is going to come with fever along with, okay, bilateral carotid enlargement. You will be thinking in terms of pericarditis, acute pericarditis. You may be thinking of bacterial causes, but you have to remember, okay, whether it is an inflammatory syndrome like sarcoidosis. So diagnosed by symptoms along with an elevated serum ACE level or lymph node, parotid, or lacrimal gland biopsy demonstrating a non-caseating granuloma and corticosteroids are the treatment. Now, okay, this is a picture showing, you see bilateral parotid enlargement. Okay, facial palsy is not so prominent, we can make up. Okay, along with this, they do a biopsy and find out whether it is non-caseating granuloma. So mainly parotid enlargement is the one which you are going to make out. Cutaneous manifestations, 1/3 of the patients. Maculopapillar lesions are the one, mainly maculopapillar lesions. Okay, apart from hyperpigmentation, erythema nodosum already we talked about. So the maculopapillar lesions are initially, they indicate a chronic sarcoidosis. It will be there, so the people, it's there for a long time, so you're not bothered about the lesion at all. So initially the lesion will be painless, probably indurated papule. Later on, the induration may be lost and the color may change. Okay, as time goes on, it may become more brownish. So this another entity you have to remember in relating sarcoidosis. All the three you need to remember. Okay, so one is the lupus platinium, was described by Arnold Lesnier. Terms of indurated plaques and discoloration of the nose, cheeks, lips, and ears usually indicates again a chronic disease. Okay, so mainly indurated plaques, discoloration of the nose. Okay, so the nose, cheeks, like almost like lupus. We're going to think in terms of the lupus. Okay, but okay, apart from this, the other findings like hilar retinopathy are going to help you to identify that it is most likely sarcoid rather than okay lupus. So nasal, cheeks, okay, and the ears to identify okay process is probably related with lupus. But this you're going to definitely treat with steroids. Now, apart from that, other complications, the ocular complications mostly are uveitis, the most common. Okay. Posterior segmental retinitis and all can be involved, but very not so common. Okay, and then dry eyes and dry mouth, Zika symptoms will be seen in chronic sarcoidosis. Cardiac sarcoidosis, only occur in 5% of the patients. The granulomas can be found. Okay, in 25% of the patients, the sarcoidosis are biopsy. Common location of granulomas are the left ventricular valve. They manifest as heart failure or so diagnosis by MRI, gadolinium enhancement will be there. That is what you will be right. Endomyocardial biopsy as the problem doing it is okay. So there are more complications there, and the diagnostic yield is less. So most of the time we go to a submicronal calcium. With steroids there will be improvement in cardiac function. But because the granulomas are there in multiple areas, in spite of treatment, sometimes it will be developing multiple episodes of ventricular arrhythmia. So that's why these patients they put a pacemaker because you can't target. There's no one area to ablate. There's no single area to ablate. It's there in the pathway. So most of the time they put a pacemaker for block and ICD for ventricular. Liver involvement here also like okay. You are going to like amyloidosis may develop an intrahepatic cholestasis. Complications there is intrahepatic cholestasis obstruction, may lead to focal hypertension, cirrhosis, ascites. Okay, but still, in spite of the cirrhosis or hypertension, the patient may well respond to it. Okay, this is also one of the cirrhosis. They are may be amyloidosis too, unless it's autoimmune involvement. Autoimmune involvement and okay. The other thing is amyloidosis where the cirrhosis itself may regress, okay, not irreversible. Bone marrow involvement may present with most of the time the commonest symptom, the commonest feature is lymphopenia. Okay, and granulomas can be identified in 30% of patients. Splenomegaly in 5-10%. So sometimes because of infiltration there may be a pancytopenia. There is a presentation of pancytopenia. Again, bone marrow aspiration of biopsy is going to help you to identify this granulomas. So hypercalcemia is one of the features of sarcoidosis. Again, it is there in tuberculosis also. Any granuloma forming condition. Okay, what is it going to do is it's going to increase the 125 hydroxylase level, 125 hydroxylase level, and because of which you may develop hypercalcemia. So that's why in granulomas or sarcoid or TB, the presentation, initial presentation will be hypercalcemia. Once hypercalcemia is there, hypercalciuria will be there, and because of increased hypercalcemia, here the renal stone, calcium stone will be formed, and patient may land up in renal failure. So all this, hypercalcemia, hypercalciuria, and renal, okay, renal stone, because of it the patient will have renal failure, particularly when there is exposure to heat. So exposure to sunlight at times is more active. T is small and okay, you develop this hypercalcemia. So what is the management in this situation or in tuberculosis, both areas you have to give a short course of steroids for controlling this. Okay, the enzyme is the granulomas. So nervous system is multiple granulomas. Okay, that is another feature of sarcoid. Most of the time, facial nerve is the most commonly involved. So they will come in the element facial pathway using the Bell's pathway, you treat them on them, and then again we will develop another same facial pathway, how we develop optic neuritis. Okay, so multiple cranial pathways are known to occur in sarcoidosis. Okay, so basilar meningitis, this deposits may be there in the spine, cord compression may happen, myelopathy, or they may present with polyuria, diagnostic presentation because of granulomas in the anterior median. Now, there is always the, okay, because multiple areas there are deposits, you think in terms of, okay, whether it is, sometimes they present to you with white matter changes, so they make always a diagnosis of multiple. So you have myelopathy, you have, okay, pituitary involvement, you have optic neuritis, what more now to help you think of multiple sclerosis. So you have to rule out the multiple sclerosis. So multiple sclerosis, what are the main differences? Meningeal or hypothalamic involvement will not be there, and extra neurological involvement, economic involvement will help you to make a diagnosis of sarcoidosis. So what areas are not involved? Breast, testis, ovary or stomach are very rarely involved. If there is a lesion there, if you think it is because of sarcoid, definitely it is suspicious and you have to do a biopsy to rule out malignancy. You can't take it for granted because these areas are very, very rarely involved. So, okay. So mostly self-limited, but ocular involvement may result in blindness. Okay. Myelopathy, I told you, paraplegia, and renal failure is the commonest one. I already told you about the ventricular arrhythmia because of patchy multiple granulomas. So finding a lymphadenopathy is the most important thing, particularly hilar adenopathy. If it is more than 2 centimeters, okay, then it is definitely significant. You have to think of sarcoidosis. PET-CT will be able to identify where are the granulomas. Serum ACE level is not very useful. Earlier it used to be done about low sensitivity and specificity. Only if it is greater than 50% of the upper limit, it is considered significant. Okay, seen in other conditions, any granulomatous condition like tuberculosis or hyperthyroidism. Okay, one important thing is the ACE levels are high. Definitely, if you think in terms of malignancy can be. So, just review. History, clinical examination, and radiological investigation, particularly, are the ones which are going to help us to identify sarcoidosis. Then you are going to do a biopsy and you can identify the granulomas. Other thing what we can do is a bronchoalveolar lavage and find the lymphocytes, particularly whether it is the ratio between the CD4 and CD8. If it is more than 3.5, it is strongly suggested. So most of the patients will not require therapy. So if you find once you have so when organ function is threatened only, you need to go. So to avoid danger or to improve the quality of life of the person only, we treat them with most of the time with immunosuppressants, particularly steroids. Now, minimal to no symptoms. Okay, there is no abnormalities of the heart or the eyes. Okay, no hypercalcemia. Then you just observe them. If the only one area which is involved, anterior eyes, localized skin involvement or involved is there, topical steroids for skin involvement. Okay, no systemic therapy most of the time. If it is multiple organ involvement, then definitely we need to give glucocorticoids, particularly prednisone is the one we use, and you taper to less than 10 milligram in 6 months. Then, okay, if they are not tolerating the steroids, okay, then only you are going to put them on any of the alternate. Okay, so what alternate drugs you can put is the commonest one if you are using a lithium or you can use azathioprine along with hydroxychloroquine. Any of the one of the drugs you can. Chronic disease, glucocorticoids tolerated. Again, I told you like the previous acute disease, continue with steroids, very low dose. Okay, less than 10 milligram. If glucose not tolerated, I told you about methotrexate and azathioprine. Okay, if they are not effective, then you will taper off glucocorticoids and add any one of the. Okay, you are going to use either rituximab, okay, cyclophosphamide or thalidomide. Now, okay, so methotrexate, you know already, like rheumatoid arthritis, once a week dosing along with folic acid. Okay, so that is one. Azathioprine, so we 50 to 150. Most of the time, these are the two drugs along with NCQ, okay, which are going to be used. Okay, going to the biological agents is very rare. You don't use biological agents. Okay, refractory acidic will be used. So most of the time, by 2 years of treatment, these people will be responding or they will be even the disease may become silent or the patient will not have any other new features, new developments cannot be there. So if it is there beyond 2 years, okay, or at least more than 5 years, then only it's considered chronic disease, and patient may develop complications because of severe fibrosis, pulmonary fibrosis, particularly if it is more than 20%, or you are going to do a DLCO. Okay, so pulmonary function test is the division you are going to see carbon monoxide less than 50%, then again the high risk of respiratory failure is going to be there. Okay, so again hypercalcemia, renal failure may be there if there is continuously high levels of calcium. These are the two most important things which you are going to think in terms of adverse prognosis.